2020 has created a new urgency around investing in community health as a bedrock of individual and community quality of life. This year, disease and death data coming from the COVID-19 pandemic, alongside discussions around structural racism after the death of George Floyd, have reshaped the conversation. The pandemic showed the vulnerable underbelly of health disparity. It became clear people of color and low-income populations disproportionately became infected and died. In fact, Black, Hispanic, and American Indian people have been 2.5 times more likely to contract COVID-19 than whites, and 5 times more likely to be hospitalized. Deaths from coronavirus largely align with the overall racial composition of the United States, with one notable exception. While only 13% of the US population is Black, 21% of those who died from coronavirus are Black. Several forces led to people of color being disproportionately affected. First, there's a higher incidence of underlying health conditions, such as diabetes, heart disease, and lung disease, that are associated with about 90% of the hospitalizations for COVID-19. People of color also have experienced greater risk exposure, since they were slightly more likely to be essential workers, representing 39% of the US population, but 45% of essential workers. For many, being an essential worker made social distancing impossible, since their role required close contact with the public and often no paid sick days. While data from the COVID-19 pandemic was already enough to spark a meaningful discussion about race and health equity, the death of George Floyd then intensified conversations about racism and its impact on health status. Right now, few of us are likely doing as much as we could to address these issues. However, we must leverage this moment of consciousness to push forward in effecting positive change. In exploring the greater context of these opportunities, let's discuss what we mean by health equity, the rationale for change, and pathways to achieving it. Let's also talk about what you specifically can do now as a leader. Ultimately, the intent is to explore the dynamics in order to shape a path for action. Simply, we can no longer say this is not our problem or our issue to address. This is everyone's problem. So we must decide if we will be architects and activists for change or whether we will simply be bystanders. As we begin our conversation, there's value to defining what we mean by health equity. Today in the United States, widespread differences in health status, such as illness, disability, or mortality, are closely linked to race, ethnicity, socioeconomic status, gender, sexual identity, and more. Inequity results in health disparities, such as increased rates of heart disease, cancer, diabetes, and asthma, as well as drug abuse and violence. The U.S. Department of Health and Human Services notes inequities are unfair, unjust, avoidable, or unnecessary conditions that can be reduced or remedied. So simply, health inequity means select people in our country unnecessarily and consistently face greater health risks and experience poor health because of their race, socioeconomic status, or other identifiers. Health inequity is largely fueled by consistent and avoidable differences in access to resources and support. So it's valuable to consider that a person's health status is largely shaped by individual risk factors, such as behavior or genetics, access to quality medical care, and social determinants of health. Social determinants of health have the most influence on health status. In fact, 80% of a person's health is shaped by the social determinants of health, rather than the work of healthcare organizations. Social determinants of health are driven by social, economic, and environmental factors that shape the conditions in which a person is born, lives, works, and plays. These differences are deeply intertwined with socioeconomic status, educational attainment, and social power. They also reflect social needs, such as access to fresh, healthy, affordable foods, safe, stable, and affordable housing, reliable transportation, safe places to play, social integration, and support. Access to healthcare is also part of social determinants of health. Key concerns are the lack of access to healthcare services and resources, such as hospitals and clinics, physicians and clinicians, culturally competent care, medical technology, and prescription therapies and medications. Therefore, for many, social determinants of health are the visible face of structural racism. Structural racism is the most complex and entrenched form of racism. It is not about our individual attitudes, intentions, and behaviors toward others. It is about macro level systems such as institutions, ideologies, culture, law, policy, and processes that interact with one another to reinforce inequality. Structural racism leads to a systematic disadvantage of one social group compared to other groups with whom they coexist. Clearly, there's a value chain here. Since social determinants drive 80% of health status, health organizations must tackle the root causes of poor health and the intertwined issues of structural racism and social determinants of health to truly elevate health status. While health organizations have discussed the importance of moving upstream to address social determinants of health and social needs for a decade, most organizations have never substantively moved from discussion to action or have created fractured approaches, largely because of resource constraints. While impacting deeply embedded social, economic, environmental, and structural factors that create health disparities and inequity is daunting, change must start somewhere, and fostering collective action through philanthropy and partnership will emerge as a vital new imperative. There are many reasons for health organizations to take a bold and proactive stance to address health equity. For example, it would align with the changing perception of the role of healthcare, elevate overall health status, achieve significant economic benefits, and support expectations for collaborative solutions. All these things validate the rightness of deepening our resolve in this space. So let's take a closer look at the rationale for action. Amplified conversations about addressing disparities come at a time when health organizations are already reconsidering and reimagining their roles. While hospitals and health systems have traditionally treated illness and injury, hospitals now face an expanding vision of their role that encompasses prevention and addresses social needs. Healthcare's new measure of mission fulfillment is referred to in a lot of ways: community health impact, population health, addressing social determinants of health, and more. However, the singular focus is to proactively elevate individual and community health status. A new article from McKinsey Global Institute articulates the opportunity well. We must pay as much attention to health as we do to illness. The real question is how to shift from a focus on disease care to a mindset of disease prevention and health promotion while ensuring effective acute care services and sufficient capacity to deal with surges and crises. This shift involves ensuring that health promotion, preventive care, and early intervention are prioritized on a par with disease care and treatment. As health organizations expand their vision of their role, improving the health of individuals and communities remains at the heart of their mission. With that in mind, there are significant vulnerabilities in our current healthcare system if we fail to address health equity. Today, multiple sources rank overall health status and healthcare in the United States below that of dozens of other countries, based on measures including mortality, disease burden, treatment outcomes, and more. One of the obstacles frequently cited to explain the United States' low rankings is the consistency and severity of health disparities. KFF notes disparities in health and healthcare not only affect the groups facing disparities, but also limit overall gains in quality of care and health for the broader population and result in unnecessary costs. Harvard Business Review echoes and expands on those thoughts in adding, eliminating racial disparities in healthcare is vital to pushing the entire system of care forward while improving quality and containing costs, so-called value-based care. Beyond elevating health status, there's a powerful financial argument for addressing equity. Simply reducing health disparities would drive significant economic value. Today, the United States spends far more on healthcare than any other country in the world, and without having the health status to show for it. U.S. healthcare costs represent 17% of the value of all goods and services produced within our country in 1 year, also known as our gross domestic product, or GDP. This 17% spend is 50% more than the next highest spender, France, which spends 11.6%. This equates to the US spending more than $9,000 per American per year on healthcare, while most developed nations spend $3,000 to $6,000 per person per year. Further, a significant percentage of this annual spend is associated with racial health disparities, including an estimated $35 billion in excess health expenditures. However, we must have an honest moment here. The financial incentives for most hospitals are not currently aligned for them to prioritize this work. While our nation is moving toward a paradigm where hospitals are compensated based upon value rather than volume, many hospitals today still exist in a volume-driven fee-for-service world. So reducing utilization reduces critical revenue. While hospital bottom lines are already fragile, this can provide a disincentive to proactively pursue community health. Still, when we consider the long game, addressing disparities could not only reduce the total cost of care, but also would support appropriate utilization of services and more whole care for patients. Finally, we must consider the position healthcare organizations occupy on the field now. COVID-19 has pushed health to the top of the agenda of not only healthcare organizations, but also of governments, corporations, community agencies, funders, and others. Therefore, it is unlikely health organizations will have sole purview to seek to solve these issues alone going forward. Further, the issues to address are complex and deep, so it would be impossible for health organizations to make a meaningful difference alone. With that in mind, there will be a growing expectation for health organizations to collaborate with others. However, collaboration can be tricky, and a new breed of partnership is also likely needed. Many health organizations serve as anchor organizations for community health partnerships. Health organizations often lead because they have the data, resources, organizational capacity, and expertise to provide leadership in this space. However, health organizations have also been criticized for imposing their own vision and solutions rather than working in true partnership with other organizations and with the individuals and communities to be served. So one of the new hallmarks of partnership will be seeking to listen and to understand the perspectives of other organizations and the lived experience of the people health organizations seek to help. Health organizations must also overcome their squeamishness around partnering with each other. Within the COVID-19 pandemic, we saw multiple instances of market competitors working together to care for their communities. So while the posture between hospitals and a single market has often been one of competition in a zero-sum game for market share of commercial patients, we must find a way to supersede competition. Simply, the focus should be on end users of our services, patients and families. And we know health organizations combining their expertise, resources, and geographic footprints would be powerful. Ultimately, pulling together the threads of a community to have a shared vision for impact and to harness the power of many resources, agencies, leaders, and funders can be catalytic in driving real change. And it's the only way we're going to be successful. As health philanthropy leaders, you also know impact-driven donors and large healthcare funders want to see cross-sector collaboration. Health funders are also increasingly giving to those outside the traditional healthcare space, such as schools or housing organizations and food banks, to drive health outcomes. In short, new expectations for crafting broad and collaborative solutions have emerged, whether health organizations are ready for them or not. So we need to be willing to shift our gaze from a sole focus inside the hospital to also looking externally at all the possibilities for collective progress toward mutual objectives. While genuinely improving the health of our communities is our shared goal, I feel sure some of you must be saying, health inequity is not the foundation's issue, or what am I supposed to do to address this? However, one of our challenges is that it's too easy for everyone to push it off their agenda. Clinical leadership often sees their primary focus within the four walls of the healthcare organization. Hospital community outreach departments are often positioned and resourced to do things like health fairs, but not to address complex social issues. Community benefit offices are often immersed in ensuring compliance with creating the CHNAs and filing the Schedule H, but often have little bandwidth or budget to drive meaningful implementation. So we need to build cross-functional teams within our health organizations to ensure this is owned and advanced. And within these teams, the foundation can play a key role. Here are 5 places to start. First, talk to your executive leadership colleagues to find out what's in the hospital's community health needs assessment. All nonprofit hospitals are required to do one every 3 years and are required to file an implementation plan. Find out what's in it and what could have potential for philanthropic investment. While your role as a foundation is to raise money to support the hospital in fulfilling its mission, this new era of healthcare has already thrust community health to the top of many healthcare organizations' strategic agendas. Second, as healthcare organizations seek to advance health equity, it is a natural place for philanthropy. We all know philanthropy from the Greek spoke of demonstrating love of humankind, and voluntary giving to foster health equity would certainly be an expression of love. Philanthropy is also well positioned to take risks by investing in new ideas and approaches that may be untested, but could be transformational. So illuminate the opportunity to foster greater health equity to donors and health funders. Today's donors are indeed social impact investors who want to affect real change. Talk to them about how the health organization can go upstream to address social determinants of health or social needs, rather than only treating illness and injury downstream. Or talk about initiatives to support access, preventive care, and more. Most hospitals will have a ready list of opportunities for charitable investment in community health articulated when their community health needs assessment. Many initiatives within the CHNAs need a financial kickstart to enable program design and development, infrastructure, implementation, data collection, evaluation, and more. Then successful efforts will need ongoing revenue to scale and to achieve sustainability. Many hospitals have said financial capacity kept them from doing what needed to be done in the past, but you can bring a high-value, low-risk alternative revenue resource to the table, and it could be a game changer. Beyond talking to individual donors, there's also value to talking to funders like community foundations, private foundations, and others about how their giving could be leveraged in this space, and in being a facilitator for accessing the many grants available to address the needs of socially disadvantaged populations. Third, talk to the foundation board about how the foundation can be more strategic in its work. How can you ensure philanthropic priorities are not only tightly aligned with the health organization's strategic priorities, but also embrace how priorities are changing as health organizations shift from a primary focus on illness and injury to a broader focus on elevating health status? Also, talk about how you can prioritize funding initiatives with clear and measurable outcomes to demonstrate impact. Fourth, while you're having conversations with your foundation board, it's also a good time to engage the board in a larger conversation around how the foundation demonstrates its commitment to addressing health equity and racism by increasing diversity, equity, and inclusion through board recruitment. According to BoardSource, today only 15% of nonprofit board members are people of color. Talk about how your foundation board composition can start to mirror your community to give a voice to all those you represent. Fifth, support your health organization in forging community partnerships. Collaboration to advance health not only can unleash access to information, infrastructure, and scale, but also could support creating more robust solutions. Partnership provides access to more data to understand interconnected issues and to identify root causes. Coming together leverages limited resources and enables resources to be directed to areas of greatest impact. Community partnership creates an environment that is more conducive to building sustainable solutions and to identifying replicable best practices. Ultimately, collective action with hospitals alongside other stakeholders best supports enhancing access to care, addressing social determinants of health, and decreasing health inequity. So utilize the strong relationship equity and trust you've built with leaders of other community nonprofit organizations, such as food banks and housing organizations, to support the hospital's goals for collaboration. Given that many donors are also community influencers, invite them to be part of building broader coalitions between businesses, nonprofit agencies, funders, and others to affect change. There is power in synergy, shared resources, and breaking down silos, and you can play a vital role in making connections. Here's the thing. Health organizations have intellectual capital, infrastructure, scale, business intelligence, and access to key populations that ideally position them to advance smart solutions to complex health problems. At the same time, health foundations have access to visionary donors and funders with the ability to invest in those solutions, as well as access to potential collaborative partners. So we must build on this moment of lift when governments, payers, funders, donors, and others are mobilized and energized to address these issues. We also must understand the risk of hesitation. If the traditional health sector, including our hospitals and our health foundations, fail to step forward to address these issues, others will. So we must decide if we choose to lead or if we want to follow. I believe you want to be a catalyst for affecting change that will lift up your community and will make health truly accessible for all. So make a commitment to have conversations about how you can support the health organization in funding strategic initiatives for community health. And consider making the intention to support equity one of the elements of deliberation around selecting future projects for philanthropic funding. You have an opportunity to spur collective action to create whole and sustainable solutions to enhance access to care, to address social determinants of health, and to increase health equity. I believe you're ready for this expansion of your role, and it's aligned with the evolving changes in the role of health organizations. So I urge you to explore how you will add value in this space alongside donors, partners, and others who wish to support health.